So hello and welcome everyone to the Pearls Lecture Series of 2023. My name is Bilal. I'm a third year medical student at the University of Melbourne. And before we get started today with a very interesting and very niche lecture, a lecture that we're all really excited about and looking forward to for a while now, I'd like to quickly have a chat about Pearls as an organization. So as some of you may know, PEARL stands for Focus for Emergency and Acute Care in Resource Limited Settings. Last year, we started our inaugural Pearls program that was run in Port Vila in Vanuatu. But since then, the Pearls team has made their way to various other places across the globe. To Tonga, we've had coaching happening in Papua New Guinea as well as Kiribati. We also have viewers today from across all these places as well, both coaches as well as learners as well. So it's very exciting to see that the program is ever expanding. And within the next 12 months, we're seeing more programs being run, and as such, our reach becoming a little bit larger as well. So it's very exciting. Today we have Dr. John O'Henry as well, who's part of the PEARLS program. And for those that are new to the PEARLS program today, PEARLS basically involves 3 days of ultrasound training or coaching as well, and that involves coaching through remote handheld ultrasound probes as well, in which attendees are to put them in their smartphones and such, and they go 3 days of vigorous training in PEARLS ED courses, and now in the next little while, PEARLS critical care courses as well. And a very interesting aspect of PEARLS is that we continue on supporting our physicians and our doctors on the ground as well by a remote imaging platform, so that we can make sure that we continue to support their learning from afar as well. So today we will be having our lecture series by Dr. Casey Parker. We'll be talking about scrotal ultrasound as well. So, Casey, I understand that most of your clinical practice occurs between Perth, Broome, and Kimberley as well. It's very interesting because your practice involves your clinical practice involves a lot of work being done in rural places as well. So could you quickly shed some light on how that differs from your practice perhaps in Perth, and how that may be similar to the clinical practice of some of our attendees today that are coming from these specific islands?
Yeah, thanks, Bilal. So I have been living and working in the remote part of the Northwest WA Kimberley region for about 20 years now. And most of the communities that we work in there are very small. They don't have really much access to formal imaging. And particularly after hours, there's usually no formal ultrasound available. And we do have some surgical services, although they are spread around. And so most of the towns wouldn't have access to acute surgical services and would require long transfers. So very similar, I guess, to some of the communities that some of the listeners today would be servicing, although we do have the luxury of being in Australia and having a very well-funded retrieval service, so we can get people from A to B relatively easily, which I'm sure is not the case in many parts of the South Pacific. So a lot of my work, I've worked for many years as a point-of-care ultrasound provider, and in the last 5 years I've undertaken formal training and become a DDU or a sonologist, so essentially working as an ultrasound-based radiologist in the emergency department in a large tertiary ED as well. So very different, once again, to what we'd be used to seeing in the South Pacific.
Casey, and just before we get started, could you also quickly talk about how you started with ultrasound as well in your clinical practice? Was this something that you knew early on in your training, or is it something that you picked up relatively recently after practicing for a while?
Yeah, so more out of necessity, my practice started with obstetric ultrasound. So I used to work in small remote communities where obstetric ultrasound was something that needed to be provided. And we had a very small handheld Sonosite C180, if anyone is old enough to remember that machine, but it had a screen about as big as your iPhone, and it fit in your backpack. And we used to take that out to remote clinics to do antenatal ultrasounds. So that's how I sort of got interested, did some basic training. I was really lucky to have a couple of really great mentors who taught me through POCUS and got involved in a lot of online education such as this, and as a student, and over the years have sort of learned more and more to the point where I'm now mostly doing teaching rather than learning.
Amazing. Well, Casey, we have lots to learn from you, so whenever you're ready, please go ahead.
All right, so I hope you can all see the slides. I'll start with my first image, and I thought I'd just throw this one out there. So since we're talking about pearls, there is such a thing as a scrotal pearl, if anyone didn't know that. And this is a scrotal pearl, which is a little calcified round object that is often seen in the inferior part of the scrotum in about 2% of the population. And this is essentially a normal variant. And what we think this is a calcified hydatid or appendage testis, which has fallen off and scarred over time. And so it looks like a little pearl within the scrotum. So usually you can't see them, but when there's a bit of fluid around them, often they show out. So just to put a bit of flavor on the day, that is what a scrotal pearl looks like. So I'm going to start by just describing how I scan the scrotum, because this is one of those scans that can be very frustrating if you don't get it right and use the correct technique, because chasing testicles around a scrotum can be quite hard to do and it to take a bit of practice. I'll give you a few pearls as to how you can make that as easy as possible. So probably the most important thing is you want to make that skin on the scrotum nice and tight so that it doesn't move too much while you're trying to scan it. And what I like to do is lift the scrotum up, or ask the patient indeed to lift their scrotum up and then bring their thighs together so that their scrotum is sitting on top of their medial thighs, so that it doesn't keep dropping down into the posterior sort of region down around the anus, because that just is really hard to get at and can make it hard to sort of get resistance. So you can put gentle pressure on. I like to create a little towel hammock top, and most young men particularly are quite shy about showing their genitals, and you can cover up their penis with the towel as well, so that doesn't actually need to be on display for the scan usually. I then ask the patient to reach under the towel and just put gentle traction on the penis, pulling it up towards the umbilicus, not firmly, but just enough to keep a little bit of tension on the scrotal skin so that it's nice and taut, so that it doesn't move so much, and hopefully smooth out some of the creases that tend to occur. And then my other two tips are that you want a lot of gel, and if you do have access to it, nice warm jelly. Nice as well. So the problem is if you're scanning, we almost always use the straight linear probe for doing this. It's really swollen. And they can do that themselves by helping you do the scan. That's much easier to do and to say, and when someone's got a lot of pain, that can be quite hard to do. But it certainly is something that the patient needs to help you with, and a bit of cooperation, you can usually get this done. I'm just going to stop and see if there's any questions as we go. Bilal just told me I can go into presenter view. I have to work out how to do that.
That's all right, Casey. That's all right. No need. You're good.
Okay, cool. Please throw up any questions in the chat, or else just stop me if you have anything to say. So the four sort of key acute scrotal things that I think we need to talk about in this context is obviously testicular torsion is a major one that we don't want to miss. Infections such as epididymolycitis or others. Testicular trauma is something that we also need to talk about. And I'll talk a little about acute hernia and what they look like, because they can also present with scrotal pain. There's obviously a lot of differentials to consider with scrotal pain, and it can actually be an abdominal problem that's causing the scrotal pain, or renal colic even can do it, but I won't go into that in this lecture. So let's start with testicular torsion. So this is a spectrum of disease in my mind. We have a concept called intermittent torsion, where the testicle's intermittently torting on itself, usually not a full twist, and can cause pain. A partial torsion, where it's usually around about 180 to 270 degrees twisted. And then you have a complete torsion, which is usually a 360-degree twist. Then, of course, you have the ischemic testicle, which is the result of the complete torsion. And finally, you have a necrotic testicle, which is what we're trying to avoid. The sweet spot for our intervention here is going to be doing an ultrasound to try and work out, have we got someone before they start heading towards a complete torsion or an ischemic testicle, and when should we refer for exploration of the testicle or get it done ASAP? Now, in the context that I work in a large tertiary hospital, we don't actually tend to ultrasound young men with acute torsion, because we like to get them seen by the urologist as soon as possible, and we don't think that ultrasound should delay that. We have 24/7 access to urologists, so that's not a problem. However, if you're in a remote setting and that's not possible, and you really need to work out what's going on. And I think ultrasound is really the only test going. Clinical examination is not great. Obviously, if it looks torted, it probably is, but ultrasound can give you some really good clues as to whether this is torsion that you're dealing with. If you're going to remember nothing else, if you look at a testicle on B mode, you're looking for a big, round, bright, and tender testicle. So a testicle that is larger than the other one. And testicles are usually sort of oblong shape, egg-shaped. But if it's looking more rounded, so it's more like a spherical shape, that's a clue. If it's bright, it can have patchy echo texture. So bright areas and dark areas as the venous congestion tends to set in, and then later on ischemic injury can happen. So you get bright and dark areas, and then it's tender. Usually there's not a lot else going on. There may be a small hydrocele in the early phases. If you're seeing a large hydrocele, that's usually a late sign, and you can see some thickening of the scrotal wall. Obviously, color flow is key here. So the problem with color flow is that if you get the settings wrong, you can make any testicle look like it's ischemic. Most of the point of care machines don't actually have a dedicated scrotal preset that can use. You can use a small parts preset, for example, but you need to make sure that the color scale is right. So normal color flow in a testicle is somewhere less than 10 centimeters per second, sort of 6, 7, 8 centimeters per second would be a normal arterial flow pattern in a testicle. But if you have your settings set at 20 or 30 as the standard spectral Doppler for another modality such as vascular, you may not see that flow because it's just too low down on the scale. So you just need to be aware of that and treat that appropriately. All right. Now, excuse me. Sorry, one moment. Sorry. Sorry, I just had to quickly chat with my wife there. So yeah, just be aware of the color scale setting and be aware that it can look abnormal if you've got the settings wrong. So this is what we're looking for essentially, is a big round testicle that has bright areas, some edema within the little septae, which is due to venous congestion, a bit of thickening of the wall, and the absence of color flow within that testicle. It's always nice to try and get the testicles lined up so you can put the probe on and see both testicles at the same time on the screen. That way, you know, if you're seeing color flow in one testicle and not in the other, it's not a problem with your settings and your color flow. It's actually a true phenomenon. It is very low flow, so you do need to have a very steady hand. And I highly recommend that you rest your hand very firmly against the patient's thigh, because any small movements of your hand while you're looking at color flow can make it appear like there is flow when there isn't actually flow. So you have to have a really steady hand for this one. In our tertiary lab, we do like to use spectral Doppler, which can be difficult. Not all machines have access to this. But on the right here, we have normal spectral Doppler flow. You need to be sampling from an artery that is in the testicle. You don't want to be sampling these little arteries that are on the wall of the testicle, because those will have a separate flow. You need to be sampling from something that's actually inside the testicle. And you're looking for this low velocity, nice pump with continuous diastolic flow. So this is a low resistance waveform with continuous diastolic flow. This is a normal testicle. Whereas over here on the left of screen, we have a very sharp peaking and absence of diastolic flow. So this is a high resistance pattern. So this is what you'd expect to see in an early torsion. So if you're seeing something that looks pointy or goes down to zero, that's an abnormal flow. And that would normally be something you'd need to act on pretty quickly. Now, the best sign for torsion does not require any fancy color flow or spectral Dopplers, but it's this sign right here. If you keep your eye on the center of the screen there, I'll just play that clip a few more times. You can see this twisting. You can see that there's actually a little knot right here in the center of the screen. And this is called the testicular whirlpool. So if you're seeing this whirlpool, what you're actually seeing is the point where the spermatic cord is twisted upon itself and the blood vessels going around in a circle, usually through a full 360 or even more degrees. And this can sometimes be difficult to pick with the naked eye. So if you put the color flow on and then scan through usually through the upper pole of the testicle up into the inguinal canal, you may actually be able to see the blood vessels stopping and starting as they go around that whirlpool. So color flow can sometimes make this easier to visualize. So that's a whirlpool sign. I'll just show you another one. So this is almost 100% specific and sensitive for testicular torsion. If you see this, there's nothing else that really gives you this appearance. And it's just a matter of fanning up and down through that spermatic cord as it goes down into the scrotum. And if you see that, then you know what it is. There is actually an intervention that can be performed at this point if you're seeing a patient with a true whirlpool, is that you can actually try and manually detort the testicle and try and straighten out that whirlpool, try and straighten out the knot and move the testicle down into the scrotum. And then you can scan again to see if it's gone away, if you've successfully done that and hopefully restored blood flow to the scrotum. Obviously, that patient then still needs to go for surgery. However, you've bought them time and you've hopefully saved the testicle. And I guess if you're working in the South Pacific and you're a long way from a surgeon, that's probably a really handy thing to be able to do at the bedside. All right, we'll move on. This one, we have to remember, there is this thing called the hydatid of Morgani, or the appendix testis, which is this little dog ear that hangs off usually the superior pole of the testicle. It's often very difficult to see. It's a normal embryological vestigial organ, but when there is a hydrocele around it, it usually stands out like that, and you can see it. That one looks completely normal, and that would not be the cause of the patient's pain. However, if you're seeing an appendix which is swollen up and bright and has some absent or increased blood flow around it, that's probably a true torsion of the appendix testis, which is the main differential for torsion. You can sometimes just identify this clinically by feeling a little hard lump at the superior pole of the testis. That's really hard to differentiate from the epididymis because that's exactly where it lies. So be aware of that. But that's the common thing that's seen at surgery when it isn't a torsion subsequently. All right, let's move on to some infections. So epididymolycitis is a common infection. We see a lot. It can be due to STI-related illness, or it can be in older men, particularly due to just simple bladder infections, which have ascended up through the bladder, through the urethra, prostate, up the vas, and into the epididymis. Usually tracks from the tail of the epididymis up through the body and into the head of the epididymis, and then into the testicle itself last. Of course, you can get orchitis as well from viral diseases such as mumps and other viruses that can just cause primary orchitis. What does it look like on ultrasound? Well, the first thing you look at really is that the epididymis, you put color flow on, and sometimes the epididymis is a bit bigger than it should be. Sometimes it's a bit brighter, and sometimes it has increased vascularity. This one doesn't look too bad to me. This is a picture of the head of the epididymis, but if that was where the person was tender, that could be epididymitis. As you move along, if you get a really thick, swollen, fat body with lots of color flow, that would be key to epididymitis. And you can see here that there's a reactive hydrocele, which is anechoic around the testicles. That's commonly seen in acute scrotal infections. And the skin becomes a bit thickened as well, usually in epididymitis. The tail of the epididymis is where we see the most nonsense. And usually you see this really bright, hot, echogenic tail, which is just at the inferior pole of the testis with lots of color flow in it. And you can develop little micro abscesses, which is this little area here that doesn't have any color flow within the tail of the testis. This is really useful for surgeons to know about because some of these will require surgical drainage if they don't respond to antibiotics. So in most cases, antibiotics is still the first line treatment for these. And of course, we always look at the scrotal wall thickness. And if you're getting up or above 3 or 4 millimeters, then that's probably abnormal. But usually that's just a secondary sign that we see. Once again, this hydrocele is a bit more echogenic. It's got some debris floating in it, so that's probably pus. And if we put color flow Doppler on, we actually just see normal low resistance flow pattern. So there's still nice low lumps with a good diastolic flow, maybe a little bit higher. But when you put the color flow on in a true orchitis, what we see is this thing called the testicular inferno. So if you compare left to right, always do that in testicles. You can see lots of color and lots of flow. So that makes you think that this is a true infection because there's a lot of inflammation going on in there. And the best way to rule out torsion is to show increased flow, and a positive diagnosis of an infection makes torsion much less likely. If it goes on for a bit longer, you can see this phenomenon, which is pyocele. So this is a hydrocele which is full of pus and started to become organized. And if you're seeing this really echogenic, gnarly looking spider webs within the hydrocele, then that is most certainly going to be a pyocele in the context of an infection in the scrotum. So that one usually responds to antibiotics, but would be one that you'd want to follow up more closely because it could turn into an actual abscess. I thought I'd throw this one in there just because we're talking about the South Pacific, and some of you may still be working in areas where tuberculosis is an issue, and TB can affect the testicles, as we all know, and you tend to get this mottled hypervascular appearance on the ultrasound with a reactive hydrocele. This can look very similar to a testicular tumor, and so I think it's difficult to say on ultrasound one way or the other. Luckily, we're all doctors and can work this out from first principles. If the person has a cough and they've had prior history of TB, then that's probably what it is, but difficult to differentiate on ultrasound. And the last thing I'd say about infection is that if you're scanning a scrotum and you see this, which is this bright echogenic material with a dirty shadow behind it, that is suggestive of gas within the scrotum or the scrotal wall. And this is concerning for Thornier's gangrene or gas gangrene in the wall. And we tend to see this in old diabetic vasculopaths, which is very common in our Australian Aboriginal population. And the other key I'd say here is that often the patient is septic out of proportion to what it looks like going on in their scrotum. So they have a scrotal infection, some red skin there. When you put the probe on, you see gas, but they're actually really sick. They're hypotensive and febrile. And this is a clue that this is what's going on. This is obviously a surgical emergency with a quite appreciable mortality rate. All right, let's move on to a bit of trauma. So trauma is relatively common in Australia because we love cricket, and cricket balls are the exact right size to hit people in the testicles. And I'm sure that the same is true in various parts of the South Pacific. I've played a bit of soccer in Vanuatu back in the day, and I'm sure that that is something that does happen. So when you are looking at a scrotum in the context of trauma, what you're truly trying to work out is, one, is there any evidence of bleeding within the scrotum? So looking for free fluid, or this is a hematocele, so blood within the actual scrotum itself. And then we're also looking to establish whether there is actually a rupture of the testicle itself. This is really difficult to do, even with the best trained hands. Looking at the whole entire surface of the tunica albuginea, the hard capsule around the outside of the testicle, it's very difficult to do in 3D to establish whether this is completely intact, and it can be very subtle. However, if you're seeing something that looks like this, where you've got a clearly malformed testicle and there's a clear fracture line running through it, and the possibility of a little bit of a discontinuity of the tunica albuginea down the bottom there, and you've got some blood, then in the Australian context where we have access to surgery, then this would be an indication to go for a scrotal exploration to try and work out exactly what's going on there and try and salvage that testicle if necessary. It's a bit of a controversial area. Not everyone needs exploration that has a fractured testicle, but it can be tricky. And if you see something like this, where there's a clear avascular area of the scrotum with free fluid and blood around it, that may be one that you can manage conservatively. However, if you're seeing something like this, where you've got clear extravasation of the seminiferous tubules, so the tunica albuginea is clearly broken there, and this is all bits of seminiferous tubules poking out into the hematocele, this is one that would normally get explored. And with debridement and trying to close the tunica albuginea, they actually do pretty well. They have more than a 90% salvage rate, whereas testicles that aren't repaired, that have a severe injury like this, it's more like 50-50 in terms of long-term viability of that testis. So important thing to look for. I'm not going to talk too much about testicular tumors, but this is a classic miss, is that a young man comes in and has some pain, and they always seem to do this thing where they retrospectively put their pain down to a trivial injury, such as I knocked it on the coffee table, or my son jumped on my testicles and now they're a bit sore. It's usually some not particularly high velocity injury and they've got ongoing pain. We scan them and we find a mass within the testicle. And this is obviously a tumor. It's got vascularity to it. And this one would need to go off for exploration. So just be aware that testicular tumours commonly present with pain, but usually the story doesn't quite match up. There's no cricket ball involved. They are relatively common in young people, so it's one of those diagnoses that's useful to make. And I'll just say that thinking about testicular tumours, this is a mass that's within the actual testicle itself. This is, until proven otherwise, this is a tumour in my head. Whereas if you see something that's outside the testicle, a mass that's adjacent to the testicle, so this is an epididymal head cyst, these tend to be benign. So if it's outside the testicle, they generally are a benign process, whereas things inside the testicle, in our context, tend to get followed up closely and usually a urology review. We'll talk a little bit about hernias, because this is something that can be really fun to do on ultrasound, but can be a bit tricky as well. I've just put this picture in here. It's one of my favorite pictures I've ever taken with an ultrasound, just showing the continuity of ascites down through the spermatic canal and into the scrotum, or into the spermatic cord, and the actual testicles off the screen there to the right. So just remember that this is all connected, and we're looking for things that are coming down through this canal and causing scrotal pain. There's a reasonable approach to doing this. I tend to just start with the probe up against the rectus muscle and identify where the inferior epigastric vessels are coming off, perforating through there. And I just follow them down some transverse to the inferior epigastric vessels, heading towards the inguinal canal. And then when these inferior epigastric vessels hit the femoral artery, or the iliac artery, so I should say, at this point, that's the point where you want to be looking for a hernia. So that's close to the deep ring. And then you can turn your probe 90 degrees and follow the spermatic cord down towards the base of the scrotum, as per the green lines there, and you're looking for hernias as you go. At each step of the way, you're asking the patient to do a Valsalva maneuver. So hold their nose and push down to see if you can see that hernial sac moving in and out of your field of view. So start from the top, move down, identify the deep ring, and then head towards the superficial ring, the external ring, and look down into the scrotum. Now, obviously, if someone has a very subtle hernia that is only just apparent when they Valsalva, that's unlikely to be the cause of their pain right now and isn't a surgical emergency. Good to know about, but not something that has to be dealt with right away today. What we're really looking for is an incarcerated or a strangulated hernia. This is what it looks like on ultrasound. So this is the inguinal canal here. These are the inferior epigastric vessels just here, just before they join on. As you can see, there's a hernia coming here. It's arising from lateral, sliding over the top. So this would be this one, C. So this is an indirect hernia, as opposed to this one on this side. See if I can get this. Oh, there is a little video. Sorry, we'll see if it plays. Apologies below, one video on here. This is what it looks like when they Valsalva, and you can see that hernial sac moving back and forth with Valsalva as they breathe in and as they push down. So that is an indirect hernia coming across. Like I say, that one's clearly reducible. It's only there when they're pushing down. As opposed to this, there's a spectrum once again from reducible that you only see on ultrasound when they Valsalva. There's non-reducible hernias. There's an incarcerated hernia, and then strangulated hernias. And as we go towards the right, these are the ones that we really care about today. And hernias that slide back and forth or even into the scrotum, good to know about. But when you start seeing bowel present, this is a loop of bowel, that's more concerning for an incarcerated hernia, particularly in young men. And then if you can't reduce this, or if you've got a good amount of free fluid around the outside of the bowel, that strongly suggests that this is an incarcerated hernia. You can put color flow on this bowel and see if it does actually still have blood flow to it. However, if the patient looks like they have a bowel obstruction, there's a good chance that they're at this end of the spectrum and needs urgent surgical intervention. And the last hernia I'll just mention briefly is femoral hernias. These can be really tricky to detect clinically, but they're actually really easy to see on ultrasound. So you just find that classic view where we look at the nerve artery vein in the femoral canal there. So we're looking across in trans, just in line with the inguinal ligament, and you're looking for the three things together. Usually when you ask a patient to take a big breath in Valsalva, the femoral vein gets big because you're putting all this pressure on on the venous return, so the femoral vein gets bigger. However, if you're watching the femoral vein and you ask them to Valsalva and something else is squashing the femoral vein, that's a femoral hernia. So this is a femoral hernia sitting adjacent to the femoral vein. And if that's squashing the femoral vein, then you know what it is. And often you can see bowel content within that hernia. Most of these will just contain a mental fat, which looks sort of grey and amorphous. So that is about it when it comes to my scrotal pearls.